Hi there, my name is Brianna. I'm going to begin with my GI NCLEX question review. We're going to go ahead and start with the first slide. It says, the nurse is preparing to care for the client who has hepatitis A. Which intervention should the nurse plan to implement? We have 1, teach the client to limit use of alcohol and drugs containing Tylenol. We want them to quit. We don't want them to limit, okay? 2, provide a high protein, high carb diet with 3 large meals a day. A patient dealing with hepatitis, their liver's inflamed, and it's not going to be working properly. So the ability to transform protein into urea for the kidneys to secrete out in the urine is not functioning right. So we don't want a high protein diet or high carb, nothing that's going to increase the demand of the liver when it's injured. We don't want that. Wear gloves, mask, gown. This is a contact issue. We're going to wear gloves and a gown. We don't need a mask. Provide rest periods alternating with moderate activity during the day. We're going to do this. It's important to know that GI patients need rest when undergoing surgery or trying to heal from their condition. So the answer for that first slide there is 4, provide rest periods. They're going to be tired. Their metabolism to break down the food for energy is not working right now, so they're going to be tired. So we'll need them to be rested. Okay. Let's see about so we talked about all those options. So the answer is 4. Number 2, this next slide, the nurse is caring for the client who has a vertical banded gastroplasty. The nurse teaches that nausea can occur after this surgery from which situation. So we have to break down our question. We have to know what things are. The vertical banded gastroplasty, that is the end of the esophagus being wrapped around the top portion of the stomach. It's not going to mess with digestion, anything like that. This is a surgery to help prevent the person from overeating. So if they complain of nausea, as mentioned in the slide, what would be the reasoning for that? So is it the first one, the stomach pouch becomes overfilled? We're going to hold that. Okay. 2, the lower half of the stomach becomes spastic. The duodenum incision becomes inflamed. The dumping syndrome that occurs from a high protein meal. There's no dumping syndrome to worry about with this surgery, other than the fact that the stomach pouch during the surgery can be overfilled with food, because the goal for this surgery is to decrease your intake of food. It doesn't mess with anything else. So the answer is 1, the stomach pouch becomes overfilled, because that's like we just talked about that. Okay. We're going to the next slide. The nurse is caring for the post-operative client who underwent an open Roux-en-Y gastric bypass. The charge nurse should intervene if which observation is made. 1, the nurse care plan for post-operative 1 indicates restricting fluids to 30 to 60 mL per hour of clear liquids. When we come from gastric surgery, we're going to be nothing by mouth, then advance to clear, then full, and then, to the normal diet. So there's nothing wrong with this restricting of this fluid here. The nurse is instructing the LPN to remove the client's urinary catheter 24 hours. That's nothing wrong with that. 24 hours of surgery needs to be removed to decrease the risk of infection. The client is wearing we're trying to intervene. So the charge nurse should intervene if which observation is made. So if you're the charge nurse and you see one of these options, which one are you going to intervene in? The client is wearing a belt BiPAP mask when sleeping during the day. Or the last one, a bottle of saline and 60 mils catheter tip syringe are the best. Okay, so the answer is for when we're dealing with GI surgery, if there's any kind of syringe in their room, do you want to call the provider before you irrigate it or do any kind of dealing with that syringe, because we don't want that that area that has been operated on, we don't want it to become detached due to manipulation of the site with the irrigation of the normal saline. So you want to phone the provider and ask them, do he want you to do that? So you want to, anytime you see a syringe in a patient room and they had GI surgery, you want to call the provider and ask if they want it to be irrigated, because frequent irrigation messing with that suture line can cause it to detach, and we don't want that. So phone a provider. All right. Our next question we have: during a clinic visit, the client provides all the following health history information. Which client statement should be most concerning to the nurse because it could describe a symptom of esophageal cancer? 1, I have been having a lot of indigestion lately. When I eat meat, it seems to get stuck halfway down. I have been waking up at night lately with chest pain. I gain weight even though I have not changed my diet. Okay, so 4, I gain weight even though I changed my diet. That's not necessarily a symptom of having esophageal cancer. You could be not making the right choices with your diet. Okay. 3, I've been waking up at night lately with chest pain. This doesn't necessarily have to pair with esophageal cancer, because you can have chest pain if you got GERD, or chest pain due to angina, angina, chest pain. When I eat meat, seems to get stuck halfway down. Okay, this is the answer. Okay, 2, because if you got cancer, that part that has it, it's not working. So if I have esophageal cancer, the peristalsis that's supposed to go on and push my food down is impaired, and is most commonly in that lower section where it connects with the stomach. So if that's impaired, food is going to feel like it's getting stuck. Okay. Provide all the following health insurance. Okay, so the answer is 2. When they eat meat and it feels like it's getting stuck, this could be a diagnostic for esophageal. Well, not necessarily diagnostic, but it can help you say, well, maybe they're maybe having some esophageal cancer, going over the history and stuff. Okay. So on the next question, following an esophagectomy, this is the removal. With colon interposition. So this is the removal of part of your esophagus and esophageal for esophageal cancer declines beginning to eat oral fluids. Okay, this is just the lower part of your esophagus being removed, and it's going to migrate with your stomach. Okay. The nurse monitors for aspiration because the client no longer has which structure. Is it A, the stomach? No, there's no removal of the stomach in this surgery. A pyloric sphincter, that's for the lower part of the stomach. That's not dealing with the esophagus. A pharynx, no, you're going to still have your pharynx. A lower esophageal sphincter, that's the answer, because this surgery is going to remove that cancerous portion and connect what's healthy and left to the stomach, so that you can won't lose your nutrition, because we need our digestive system so that we can survive. Okay. So our next question is, the nurse is caring for the client who was 6 hours post-open cholecystectomy. Some of these words is hard to say, so if you know what it is, you can call it what it is. So this surgery is a gallbladder removal. Okay. The client's T2 drainage bag is empty, so that tube that drains the exudate so that it doesn't clog up your tissues, that has been it's empty, and it's not supposed to, especially after we just had surgery. Um, the client's T2 drainage bag is empty, and the nurse noticed slight jaundice of the sclera. Which action of nurse is most important? Is it A, repositioning client to remote T2 drainage? B, telephone the surgeon to report the findings. 3, ask the CNA to obtain blood pressure. 4, record the findings and continue to monitor client. Record the findings and continue to monitor. This is already a complication happening. This is jaundice. The eyes are yellow, so this is letting me know that my liver is something is backing up to where liver can't function and get that bile out. Henceforth, there are a complication with the drainage. Okay, so we're not just going to record and continue monitoring because there's a complication already had. No. So 3, ask the CNA to attend blood pressure. What is that going to tell me? That's not going to give me enough information, and for what? Just the blood pressure for what? Okay, that don't make sense. 3, telephone the surgeon to report these findings. That's what we're going to do. Anytime someone appears jaundice, yellow on the skin, or the whites of the eye, this is what it is. So this is bad because if my liver is not working, it's not draining the bile, it's also not able to do other functions that it's supposed to. Henceforth, the removal of ammonia, which when we eat protein, our liver breaks the protein down. It converts to ammonia, which is a byproduct of protein being broken down. And the liver turns the ammonia into urea, and it gets excreted via the urine. Now, if the liver is not working, ammonia levels go high. And if ammonia is high, is not able to transfer the ammonia to urea, this can cause LOC changes, cause comatose, and even death. So they're going to get their waste in ammonia form. It's going to build up, and this is bad. Okay, so that's why we're going to telephone the surgeon to report the findings, because we want to get that ammonia out of their system. Okay. And what would they usually do? They're gonna they're gonna give them some lactulose a lot of times, and I can't pronounce the name, but it's they make it go to your. Okay, that's the one. Okay, it's another one, but no need to. Sorry. We're gonna continue. Okay, so anytime there's jaundice, we're going to notify the provider. Okay, now we're going to move on. The nurse is preparing to care for the client who just had a Whipple procedure. What should the nurse include in the immediate plan of care? Monitor blood glucose levels. I like that. Initiate internal feedings. Irrigate the NG tube with 30 mL of saline. Remove the epidural line. Okay, so 4, remove the epidural line. No, we gotta understand what the Whipple procedure is. That is the removal of your bile duct, your gallbladder, the top part of your pancreas. Okay, it's a massive surgery. So having all that removed, we're gonna be losing our insulin production there at the top of that pancreas. So we're going to have to watch for those glucose levels, okay? If it might be too high, or it could be hyperglycemic with that organ being, part of it removed, is not able to function the way it's supposed to. So That's the answer. Okay. Our next one says, while assessing a client with acute pancreatitis, the nurse sees the skin appearance illustrated. What should the nurse what should be the nurse's interpretation of this finding? 1. Portal hypertension has developed from the acute pancreatitis. The pancreatitis doesn't cause portal hypertension. See what your blood stain exudate from the pancreas occurred. Yes, we gotta understand that in pancreatitis, those enzymes have let loose when they wasn't supposed to. They're supposed to wait till they get into the duodenum before they activate, but they get activated inside the organ itself. So this is going to cause some tissue damage that leads to bleeding. This is internal bleeding, in a sense. And no, it's not in a sense. It is internal bleeding. So when that the exudate leaks from the pancreas, it creates this bruising that you will see in pancreatitis patients, and it's called Gray's-Turner sign. So it radiates goes to the back as well. So so that's why that marking is there, the seepage of the content. All right, so we're on to our next one. After receiving the shift report, the nurse is planning care for 4 clients. Prioritize the order in which the nurse should plan to attend the client. Okay, so let's look at our options. The client with ascites who is having mild dyspnea with activity. Ooh, no, that's not a good thing to be doing. Okay, the client with peptic ulcer who now has severe vomiting. We gotta watch for dehydration here. And the first option, you need to watch for hemorrhaging. Those ascites are fragile vessels that get big like that due to portal hypertension. So something going on with the liver, like in cirrhosis, can cause portal hypertension. Let's continue. The client who had a colonoscopy and is having diarrheal stools. Okay. The client with Crohn's disease who received an initial dose of it's an it's immunosuppressant drug. Okay, and it's having generalized rashes. So 4 is going to be my priority first because they're having an allergic reaction. My second one is going to deal with the patient who's vomiting. They're having severe vomiting. I want to check for their hydration status because this can lead to dehydration or in a hypovolemic shock. Okay, so person who first one, they're already at risk for anaphylactic reaction due to the generalized rashes. So that's why we're checking them first. Our second one is going to be the client vomiting because we want to make sure they're not going to hypovolemic shock. And our third one, the client who has a colonoscopy and is having diarrheal stools. Okay. They're at risk for dehydration too, but the second one is severe. Okay, when you have a peptic ulcer and it gets to scarring, it creates a gastric outlet obstruction, and it can lead to projectile vomiting, and this is very bad if it's not fixed. Can die from this. All right, so the answer would be 4, 2, 3, and 1. All right, so we got about 4 more. Okay, let's pay attention to our graph here. So when admitting the hospitalized client, the client's daughter presents the medication list illustrated. After reviewing the list, which nursing action is most appropriate? Okay, so we got lactulose, what we talked about earlier. That's for ammonia. So this let me know that my patient's having some liver problems. Okay, pantoprazole, got 40 milligrams of that. That is to decrease the stomach acid. It make you think the person maybe have some GERD. Propranolol, it's a blood pressure medicine. In other cases, it can be used for other stuff. Okay, like decrease bleeding, because it's going to decrease the blood pressure anyway, so it makes sense. We have rifampicin, which is if I'm not mistaken, this is an antibiotic. Okay, got Lasix. There's some fluid going here. Phenytoin, spironolactone, Benadryl. Okay. So with the fact that we have the lactulose, means my ammonia is high. So this is bad, can go to detrimental state here. So one aspect of history of peptic ulcer disease and infections, you will want to see that because of the pantoprazole, which is for help with GERD, and PUD to decrease gastric acid. But that's only one pill. I'm looking at all the other stuff, and it's a lot of stuff going on here. Assess abdominal pain and palpate the abdominal girth. You want to do that in the sense that given that they have lactulose, so an impaired liver for long can lead to portal hypertension, but it's not saying anything about cirrhosis, okay, which is where that usually goes to. Teach and initiate droplet isolation precaution. It's not telling me I have anything. Okay, then 4, assess orientation, measure abdominal girth. We're going to do that one because of the ammonia levels, which is why they're taking the lactulose, and the abdominal girth to check for portal hypertension. This patient looks like their diagnosis is cirrhosis, even though it's not saying that. So the answer is 4. Okay, here's our next one. The nurse is caring for the client who is 6 hours post-open gallbladder removal surgery. The client's T-tube. Okay, we did that one already about the provider. We're going to notify the provider because jaundice. Okay, so we're going to go ahead and go to the next one. The nurse is caring for the client with acute diverticulitis, which findings should most prompt the nurse to consider that the client has developed an intestinal perforation. What do we know about perforation? This is intestinal content that has leaked outside of itself into the cavity in which it's held, and this is life-threatening, okay? Because it's the bacteria that is open to a wide range of space to do damage, okay? So how do we, what symptoms do we know? So if I got peritonitis, inflammation in my peritoneal cavity that's around my organs, I'm going to maybe have some hard, abdominal distension. Okay, it's going to be kind of hard. Okay, let's just read our options. White blood cells elevated. We're trying to find out which client has developed intestinal perforation. The white blood cell, yeah, it might tell us something, but it could it could be elevated already due to you already having an infection, which more like like diverticulitis, white blood cells is elevated. Okay, so temperature of 101. That don't necessarily have to be that peritonitis. You could just have a fever, a low-grade fever. Bowel sounds are absent. Now, this one sounds like an educated guess, because if my bowels has got a hole in it and not able to work anymore, all that fluid come in to, and through the opening. Okay, so want to watch for toxic megacolon, when the bowel sounds are whack, because this is where the whole thing can perforate. Okay, but if they're absent, my bowels are not working, and this could be prompt me to believe that their bowels have burst. Okay, absent bowel sounds. Reports intense abdominal pain. Well, they have diverticulitis. They're going to be in some pain due to inflammation that's already associated with their primary diagnosis. And depending, everybody's pain level might be different. And what's severe might not be might be the same with what they have already experienced, and so that's not a good way to tell if someone's bowel has perforated. We want to listen to those bowel sounds. If you don't hear them, this is an emergency. Okay, we need our digestive system so that we can eat, take in sugar, have energy to move everything. I got two more. The nurse assesses a client previously diagnosed as having an inguinal hernia that's down there toward the legs. The nurse considers that the client's hernia may be strangulated when which assessment findings are noticed. So you gotta know what strangulation is. It's cut off blood circulation. You have a hernia, it protrudes your abdominal wall outside of you. It's outside of you now, and depending on how small that hole was that it came out of, it can strangulate it. So what are some signs that can help you just find that? Abdominal distension. When you got strangulation, there's going to be some inflammation around the area that can lead to some distension. There might be some distension there. Also, you have your bowel outside of your abdominal wall, so it's distended. Dyspnea with exertion, that's not necessarily a factor to tell me if I'm having strangulation. I could be tired just because I'm tired, or had surgery, I'm tired, cancer, I'm tired. Severe abdominal pain, this is a good one here. Strangulation, the pain associated with tissue dying or blood loss from a tissue is going to lead to pain. No stool for the past week. That's a good one, because if strangulation, if my bowel is strangulated, poo can't get past. Hyperactive bowel sounds, they're gonna be hypoactive. Our bowel it's not moving, so we're not gonna be hearing any bowel sounds. So I'm going with 1, 3, and 4. And okay, our last one. The nurse is caring for the surgical client during the first 24 hours after an abdominal perineal resection. Okay, which action should have priority? So after abdominal perineal resection, okay, provide a diet that's low in residue. You're gonna have a clear diet, or nothing mouth diet first, then clear. So that's too sudden. Okay, check the colostomy bag for stool amount. Check for stool amount. Well, and you have to also give clients after having GI surgery time for poo. So 24 hours without pooing is normal. So that's not really a scare. Assess the perineal dressing for drainage. Yes, because we don't want them to have infection. Okay, when you do GI surgery, you're going to be on antibiotics. It's very easy. You're dealing with a system that naturally has bacteria inside of it, and you're doing surgery on it. You can easily puddle some E. coli that's found in your poo and splash it somewhere else. So we really want to watch for infection when we're dealing with our GI. So assess the perineal dressing for drainage is the answer. All right, we finished our 15 question NCLEX review. I'll be doing more. Thank you for your time. I hope you learned something. All right, thank you.